Dharmendra.
Yes, sir. Yes, sir. I'm listening. Yes, yes.
Yeah. So once we start the presentation, we will take the presenter and immediately finish question and answers, right?
Yes.
So that we can relieve the presenter then.
Yeah, fine. No issue.
Have you loaded up Juliana's slides?
Yeah.
Dr. Juliana will load from that.
Okay.
Yes.
Right. So she will share the screen. So we
Yes,
can
we will
start.
start.
Maybe we can start a minute early because already people are logged in on the main host. We'll start a minute early so she can start on time.
Yeah, that's fine. So let us start, and I will just again will say a lot of thanks to you, Dr. Sasank Jyoti sir, for having this session, for the meet the experts and taking us through the diabetes and COVID era from east to west. Would just request you to moderate this whole session
Right.
and invite our next speaker.
Correct. So thank you, Dharmendra. I think we are in difficult times across the world, and today what we are going to do is we are going to go across global experts from across the world, and from their geographies, they will tell us how they had their respective countries have managed COVID and diabetes. And we start from one of the global epicenters of the first epidemic of SARS-1, which is Hong Kong. And we have none other than Professor Juliana Chan, who is a world famous expert researcher, clinician scientist, originally who graduated from Liverpool, from United Kingdom, in endocrinology and clinical pharmacology. She is currently a professor of medicine and therapeutics and founder director of the Hong Kong Institute of Diabetes Obesity, and she is the director of the Clinical Research Management Office at the Chinese University of Hong Kong, Prince of Wales Hospital. Her major areas of interest include epidemiology, genetics, clinical trials, and care models in diabetes. She is one of the major principal investigators for the NIH funded Global Diabetes Consortium. She is also actively involved in the Hong Kong government fund. Am I audible? Somebody is saying I'm not audible.
That it is there, but it is you are audible to me, and I think other
You are
panelists.
audible, sir.
Yes, you are audible.
Little bit
Yes, sir.
Right.
louder.
Right. Correct. So, and she has been very actively involved in various study groups, particularly in the Asia Pacific region. She has designed the Cambridge Diabetes Epidemiology course, the Asia Pacific Diabetes Epidemiology core course, and in 2011, her center became one of the 8 IDF centers of education for commitment to the use of professional education and research to change practice and influence policy. She is currently one of the members of the steering committee for the Hong Kong government framework to control and prevent non-communicable diseases. So, Professor Juliana Chan, if we can have you share your screen and start your presentation. You have 15 minutes, and then we'll have a dialogue for maybe around 5 to 8 minutes or 10 minutes. And if there are any questions, we'll be happy to ask you those questions. Thank you so much, ma'am.
Thank you very much. Can you see my screen?
Yes, yes.
Okay. First, I would like to thank the organizing committee, particularly Dr. Bazou, for inviting me to this e-conference. It's very exciting to be able to interact with many colleagues in India and also around the world. So over the next 10 to 15 minutes, I'm going to share some of my insights from COVID-19 and diabetes. I think the world is now facing 2 global pandemics, diabetes and COVID-19. They share similarities. Both of them are silent killers. Both of them are due to changes in our ecosystem, and both can collapse the healthcare system economy if not managed properly, and that both are potentially detectable, preventable, and treatable. And yet both of them require government intersectoral and individual participation. This is really just the snapshot, regarding the situation of COVID-19. According to the WHO, currently we now have 8 million people affected, 415,000 deaths, with the majority occurring now in America and Europe, and also in other countries. I think now there are enough data showing that there are certain vulnerable groups during this epidemic or pandemic of COVID-19 actions that put these people very vulnerable. So in a way, I think the COVID-19 is a wake-up call for all of us that social and care disparity can actually affect all of us. And Hong Kong is actually part of China, as you could see. We are, because of the SARS 2003, I think maybe the community is a bit more prepared. It's a bit more prepared. And to date, we have in this city 7 million people. In this city of 7.5 million people, just over 1,000 cases of COVID-19 was confirmed, with 4 deaths and 3 being critically ill at this moment in time. So in order to understand a little bit more, about our healthcare system, I would like to share a little bit of historical perspective. So Hong Kong has a 7.5 million residents, many of Chinese descendants, has always served as a gateway between the Western world and mainland China. Returned to sovereignty of China in 1997 with status quo for 50 years. But because of the British rule for 150 years, we have adopted the UK NHS system with universal health coverage. So in 1990, the Hospital Authority established to actually run all the hospitals and clinics in the public sector and employs 50,000 staff with 7,000 doctors. Half of these account for about 50% of all medical workforce. Because of its very heavily subsidized nature, it provides 90% of acute and chronic care, including foreign workers, and sometimes even to people who actually are visitors. Since 2000, it has developed a territory-wide electronic medical record system with on-site dispensing, and it has provided a very rich informatics database. Currently, the public sector uses about 3.5 of GDP, which is equivalent to about $8 billion to manage these hospitals and provide care to the public. At the same time, we also have a very vibrant private sector, which also account for about 3.5% of the GDP, mainly by insurance or out of pocket. And these private healthcare facilities mainly perform procedures and provide episodic care. Because we were the epicenter of SARS in 2003, we recognize the importance of collaboration, cooperation, as well as information sharing for common good. So currently, since the pandemic of the COVID-19, there has been very close collaborations between the hospital authority that runs the clinics and also the hospitals, as well as the Department of Health, which obviously has been very diligent in using tracing and also treating and also quarantine to reduce the impacts of spread. And these institutes are heavily informed by the academia that actually provide the scientific guidance in terms of treatments and also detection strategies. Meanwhile, the community, as you could see, are very cooperative in terms of wearing face masks. You could see that nearly 95% of people has been wearing face masks and practice social distancing, hand washing. Since January, we have been closing the borders to China and many other countries, and also a lot of the schools and universities were closed, and people are working from home. But of course, as with the rest of the world, we also now have to deal with the social economic consequences, the unemployment, and the expected increase in terms of mental and physical health, particularly for those silent diseases like diabetes. So against that background, let's move to diabetes. I think diabetes NCD is really another global epidemic, and yet it has offered huge opportunities for early prevention. I think there are both modifiable and non-modifiable risk factors for diabetes and NCD. This is very much related to demographic data such as age, sex, ethnicity. Education is very important. The family history, which may be genetics or shared environment, and together with the acculturation and globalization, these people might develop these modifiable risk factors, mainly glucose, high blood glucose, blood pressure, abnormal lipids, and obesity, which determine the age of onset of diagnosis, which in turn would then actually determine the disease duration and gives rise to a generalized vasculopathy, neuropathy, and also inflammation. And this will be translated to major cardiovascular and renal complications, and depending on the access to care and also competing causes morbidity and mortality, we might have other consequences such as cancer, depression, frailty, etc. And of course, this all culminate to multiple hospitalizations and premature death. And yet over that 20 or 30 years of trajectory, this can be markedly changed depending on access to care, drugs, access to education, self-management, emotion, and lifestyle, as well as ongoing support. And I think it really does, and in our efforts to try and tackle this problem, I think we need to also appreciate the importance of macro environment, where policy systems play a very important role. This is really just showing that sometimes the government is really important in terms of investment to make care more accessible. And here you could see that actually compare to US and also Europe, where there is a declining rate of cardiovascular diseases, we see a threefold difference in terms of the stroke rate and also ischemic disease rate in India, which is not really moving very much. At the same time, when it comes to practice, we also need the care settings in order to bring out the best of medical knowledge and expertise. And here one could see also, despite patients having similar access to medications, laboratory investigations, etc., people do much better in clinical trial setting because they have additional support as compared to the situation where just receive random care, highlighting the importance of care organization. And importantly, the person is also very important. And this is really some of the latest analysis from our diabetes register, where there's linear relationship between years of education and outcome, even adjusting for all cardiometabolic risk factors and access to medications, so that people who have university education and pre-university education stand a better chance of surviving compared to those who only have secondary or primary school education. So really, I think since 1995, when the economy of Hong Kong was booming and we see this epidemic of diabetes, we have no choice but to change the way how we deliver care. So using a trio team by training nurses and also using non-medics, we were able to actually redesign the workflow and then providing more structured assessment, develop a database, and also organizing diploma courses to train staff. After 5 years, this protocol was adopted by the hospital authority, and this which then provide a structured assessment, complication screening services at diabetes centers. And then meanwhile, we continue to use the database to actually develop risk equations and to confirm the benefits of team-based care. In 2007, we set a foundation and digitalized the concept, the so-called JADE program. In 2009, this also motivated the hospital authority to adopt the risk algorithms and incorporate that in the EMR system, and that provides a territory-wide risk assessment program in both the primary and care settings. Now, with this ongoing data collection on a territory-wide basis, we now actually have a very large database, the Hong Kong Diabetes Surveillance Database, which actually provide quality assurance as well as tracking of outcomes to inform practice and policies. Now, using these kind of databases, we can really learn a lot from our patients, and this is really just one of those data that we have reported, showing that the relationship between glycemic control and also the hazards for all sites infections, respiratory tract infections, skin infection, and genitourinary infections, so that we are not just dealing with chronic infections, chronic complications. We also have to look after patients who are also susceptible to acute emergencies, such as infections and also like COVID-19. And in this analysis, we can also see the heterogeneity, and that all people with diabetes are different. And so people who are very well controlled A1C, short disease duration, no complications, normal body weight, their risk of having infections-related hospitalization might not be particularly increased. On the other hand, people with worse A1C, people who are smoker or current smoker or active prior smoker, who are obese, people with prior history of heart disease, and all have increased risk of hospitalizations due to infections, and these are all additive. And here we could also see the use of lipid-lowering drug statins were also associated with reduced risk of infection-related hospitalizations. With this kind of data-driven integrated care, we could really see over this 16-year period progressive improvement in terms of the A1C, the blood pressure, and also the lipid. However, there is still this inevitable upward drift in terms of the A1C and blood pressure, except for LDL cholesterol, which is mainly due to the use of statin. But it is in a way rewarding, satisfying to see that overall there is actually a declining trend. So recently, we actually looked at these 0.8 million people with diabetes who are now under the care in the public sectors, and with this collective effort, multi-pronged strategy, not just the reform of diabetes service, but also a lot of health promoting activities and also various kind of community efforts, including increased awareness, etc. We could see 50 to 80% decline in terms of all-cause death, as well as major complications. However, we are not really seeing this improvement in the young people. And this is really just one of those papers that we have reported, showing that in these young people diagnosed before the age of 40, these people might spend up to 100 days in hospital during their lifetime. And these these hospitalizations are due to multiple causes, including hypoglycemia, infection, renal or cardiovascular diseases. But what's concerning is that in the early stage of diabetes, many of these young people actually have mental illnesses, showing that this is an area of unmet need and that we need to learn a bit more in order to improve outcome. So, this is really, I think, the COVID-19 and also diabetes share similar features, and that is very often they are silent, and that data are very important to help us to prepare the community and to protect them and to prevent them from having these devastating diseases. And these data are very useful at both the patient, provider, and systems level. And using, we now have all the knowledge that's in our armamentarium. We now have to implement them. And I think, using a trio team, for example, non-medics and also healthcare assistants and nurses, we can actually start registering patients to assess the risk, to stratify the risk, to review the control of these risk factors, to control them, and then also to recall these patients to avoid defaults, and then also to enforce compliance with targeting and self-management, treating to multiple targets, treatment with organ protective drugs, of course, ongoing medical and also psychosocial support. And hopefully, these data will also help us to actually monitor the outcome of these individuals in order to inform practice and policy. So thank you for listening.
Juliana, thank you so much. This was an awesome presentation, and we are really thankful and grateful that you could call out this very nice presentation. I would just ask you two simple questions. The whole world is locked in, and Hong Kong has started normal life. So can you tell us how was Hong Kong able to start normal life from a COVID perspective? And then we will have 2 or 3 questions on the diabetes perspective. Your diabetes care model should be replicated across the world. And I think you have gone in a very systematic way to reduce not only mortality but morbidity by just showing that if you have a systematic registry, systematic database, and appropriate interventions which are timely and appropriate, you have shown the world how diabetes can be managed effectively from a public health standpoint. So that's wonderful. But Juliana, we really are very impressed the way Hong Kong initially was down almost to zero. Then there was a little mini spurt again, and you are back to normal again. So how did you all achieve that? That's what everybody wants to know. I am from Mumbai, Dr. Mishra is from Delhi, Dr. Bansi is from Ahmedabad. We are all hotspots here, and we are all struggling. So we want some pearls of wisdom from the COVID standpoint, though that's not your domain expertise. We still want to know how you all could handle it, because it will be very learning experience from people in India. It will be very wise and appropriate for you to tell us some tips which may be public health, which may be very laistic, but I think it's important to know from you how Hong Kong has done so well.
Thank you, Dr. Joshi. Obviously, these are collective efforts. I think it is important to note Hong Kong is actually very small, right? It's only a 7.5 million city. And I think sometimes smallness has this actually advantage. Sometimes I could really appreciate, the challenges when you're really dealing with big country, like England or UK or India, the diversity in terms of population, in terms of systems. But in a way, Hong Kong has always served as a little bit of a experimental platform. I think this is really where you have really east meets west, so to speak, right? A population undergoing a lot of modernization, the good consequences and the bad consequences. I think there has been a lot of debate in terms of wearing masks. And I think because of the 2003, I think people in Hong Kong has really not resisted at all in actually wearing masks, right? You see, so at the beginning of the outbreak, there was a lot of worry that we do not have enough masks, right? And so people were actually at that time getting masks from all over the place, from Thailand, from around us, and then sending it to other countries. So that is very important. I think the social distancing is very important. In January, they immediately shut down a lot of the universities and then the schools and all the government departments. And so then all the companies actually follow suit. And I think that helps. And that reduced the crowdedness because Hong Kong is very crowded. I think those two are very, very important. Of course, the Department of Health is also doing a lot of testing, tracing, and every day, the Department of Health and also the Hospital Authority are actually on the news, telling people what are the situation, and also all the hospitals are prepared, etc. So I think from that point of view, I think Hong Kong has done quite well. And also, I think nobody is denied care, and that is really very important. Because so all along, our hospitals and clinics are all open up, right? And so people can still have their medication, and can still have their body checks. And of course, some people are worried to come to the public hospitals, then they go to the private clinics. So I think it's the choices that actually make a little bit more controllable. Even for the sick and the poor, there are also quite a lot of philanthropists, right? And also communities and NGOs who actually go out and help, for example, the elderly, the aged at home. And so we're really very glad that we don't have outbreaks in elderly homes. So, I think it's really the whole mobilization of the community that has actually helped us to get through this crisis. We're still at a crisis. Of course, I think the government, despite all the criticism, they have also pouring out of money, right, in order to keep things going. So, I think in a way it's the preparedness of the healthcare system that is actually quite important. So I think, but of course, I think there's still a lot of things that we have to do. But what I really have learned is I think that people with diabetes in Hong Kong, they are very fortunate because they really have very good care, right? They have access to nurses, they have access to medications, and we could see, our mean A1C is only 7.5%. And I think that's for a public funded system point of view, I think that's really not very bad. I mean, that's really quite good. And that might also explain the really low rates of mortality and morbidity, even if they contracted COVID-19 because they're detected early and immediately they get isolated. That said, among those 4 deaths, 3 of them have diabetes, right? And 1 of them actually have CKD. And I think the first death was actually a 35-year-old man who's very obese and also have diabetes. So there are still individuals who are vulnerable.
Thank you, Julian. I think you have shown the world how to manage diabetes and keep A1C at 7.5, where I think United Kingdom has struggled, Europe has struggled, US has struggled. I'm not even talking of others. So I think you all have really shown the world. And I think what you told us is very elegant, that masking and distancing makes a difference. So are you all having conferences in hotels? Have the tourists started coming back? Are the malls open? These are standard questions. So that's what people would love to know. And we are struggling here. I can see Partha here from UK. I'm not so sure whether they are trying to open up. We are trying to unlock, But I think what I saw from the this thing that Hong Kong has already started unlocking, and I think there is almost a near normal life. Is that true?
Yeah, I think now the border will be gradually open on the 7th of July, right? And
Okay.
so, I think people are already planning trips, right? But I think with the face wearing, I think that really does help quite a lot as well. I think this is a bit of a culture. We never used to wear masks, but I think the 2003 had a very, very strong memory on us. I think that has a very strong impact. So I think people do not resist that. I think all the schools are open now, universities are open. We never were really locked down, right? Actually, life has been going on as usual, but it's just a bit more quiet. But I know with the opening of the border, of course, we have to be prepared for the second wave, and that will be challenging, right? I think it
Great.
seems good at the moment, but I think we have to be prepared and always be on the guard. You know.
So thank you, Juliana. There are two quick questions on diabetes. One is you made a reference to people below 40 and mental health problems, and these are often ignored. So in your care teams, does the nurse double up as a counselor, or the doctor double up as a counselor, or do you have special counselors in your public health system? That's number one. And the second question is that your impact on the lipid levels was outstanding, but blood pressure and glucose levels was not that outstanding. So what more are you going to do to address that? So these are the two questions. You can take your time on them.
Yeah, I think of course the nurses are very critical, and I think the hospital authority, having seen some of the results, because we initiated that care model in 1995, so they have been observing what we've been doing. We also published a paper, which I think is actually useful. We presented those findings in some of the conferences where hospital authority administrators meet, so that we tell them what we've been doing. And then other consultants also come and visit what we've been doing. So they then start lobbying for support. And so then they create positions for diabetes nurses. So previously, all the nurses, when they get promoted, they have to go back to the ward and do a lot of administrative work. But then they actually are now working in the diabetes centers as nurse consultants. So it takes time, to build the capacity. But we have in this small city, we have now nearly 200 diabetes nurses. And they run those diabetes centers supported by the diabetologists. They play a very important role in train the trainers. So in 2007, when they roll it out to the primary care, the diabetes nurses teach a lot of the nurses in the primary clinic. But because we have a very structured protocol with a very good databases, so they just follow it. And that actually gives a lot of structures. The risk algorithm they have actually adopted, so also help the primary care doctors and other people who are not so familiar with the field, that they can triage people. So I think those are, of course, once these patients are, once these data are collected, then I think it's the beginning of an education. It's the beginning of intensification of treatment. So that's why I really think data are very important. They also serve as counselor. As with many parts of the world, psychiatrists and psychologists are very scarce. So I think this is one area that we need to work on. And currently, we're discussing with our psychiatrists to identify these young patients who actually, many of them have depression, bipolar disorders. So it's still a lot of work that needs to be done. So I think regarding the ABC, I think the use of statin has been expedited because of the generic. So I think since 2007, when statin become generic, I think everybody will put on statin. Blood pressure and A1C, as with obesity, so much is behavioral, right? Blood pressure is also getting a bit better now. It's like 135. So we usually tell our patients that of these four risk factors, very fair, two belong to us. We prescribe statin and blood pressure lowering drugs, 70% of the job. Then they just have to take it. 50% of the risk factors are managed. The other two, then 70% belong to them, and we only provide guidance. So I think, I think this has been, so when we see this data recently, we published in Diabetology and a few others, it was very gratifying. But of course, like in US, they've also noted that its initial drop, but then gradually there is this kick up again. So we really do need to monitor the situation. because sometimes, it might overwhelm the system, and we might need to put in even more resources to look after these people as they continue, because we have to look after these people for 30, 40, or 50 years. It's a huge resource implication. But I think it's worth the effort. Yeah, because they also have academics to also evaluate the cost effectiveness and to see whether it's worth actually investing. So there's a lot
So,
of academic inputs as well.
so congratulations, Juliana. You have been simply outstanding. Many of us look up to you and your models from Hong Kong, both in diabetes care and COVID. We wish you all safety and all happiness, and we are very grateful that you could bless us and share some of your experiences, which are simply, they have left us in awe, because we wish we can replicate some of that in some parts of the other parts of the geographies. Thank you so much. We
Thank you so
really
much.
appreciate. Yeah.
No, that
So our
was
next speaker. Yeah. So our next speaker is Dr. Anup Mishra. Professor Mishra and all the panelists are welcome to stay on, because it's east to west, but it's up to them. We have the flexibility. Can I have the slides for Professor Anup Mishra? Uh, Professor Anup Mishra needs no introduction. He's a Padma Shri awardee. He's a mentor to many of us. We look up to him for guidance. He is the